the network for the AV industry.
What are you listening to?
This
is AV.
This
is AVNation.
This is AVNation.
This is Tim Albright with AVNation with an AVNation special, taking a look at telemedicine. And first and foremost, congratulations to an old friend of mine, Mr. Joel Billheimer, who is now with Pexip. Welcome, sir.
Thank you. Good to be here. And Pexip.
Both. Also with us is a cohort of his, Derek Atkinson, solutions architect with Pexip. Welcome, sir.
Thank you. Happy to be here.
So something that's happened this year, Joel, and Joel comes from the integration side. He's a longtime AV guy. Derek's more on the software side with Pexip, comes from software. So we're going to wrap these two kids together and talk about something that's happened in really the medicine world in the last 9 months. When COVID happened and the lockdown started to happen, one of the things that got immediately impacted was doctors. My dad is 70. He's retired. He's but he still goes and sees a doctor every once in a while. And hearing it from his side, from a patient side, was fascinating. And I understand he's in Florida. We're going to talk about some of the legal challenges that have happened over the last couple of years and those hurdles that suddenly got knocked down this year. But hearing it from his side was really fascinating. And this is a guy that I still, 10 years ago, still programmed his VCR, right? So that's who this user is. And hearing his experience of getting his iPad out and having a conversation with his doctor, and that was his consultation, right? That was his annual review.
Mm-hmm.
Sure. And my 70-year-old dad's introduction into telehealth, right? Telemedicine. And he was incredibly, gratified by it, and it helped him and it worked and all that jazz. So Joel, when you look at, not just the speed of the ramp up that had to happen,
Sure.
What is it from an integration standpoint, that folks have to have those skill sets that has to be in-house, or you have to get in-house quickly to make sure that you can start providing, telehealth and telemedicine services to your medical clients?
Yeah. So I think in the AV world, we have traditionally been in the position of being the experts, right? We go in and we basically tell a facility manager or an IT group or whatever what they need. That's frankly how every dealer that I've ever worked for or been associated with works. There is sometimes a question of trying to convince them that they actually need the service, but more often than not, you are upgrading an existing facility where there's new construction and everyone wants the latest and greatest toy, the flashiest color, the loudest audio. And so that has always sort of been a given even as part of that discussion. In telehealth, it's a little bit different because you are taking a transactional relationship, but a trusted one between patient and provider that has existed for literally thousands of years. And you are now trying to insert yourself into it, saying, okay, I know that the way that you have done things you think has worked, but now you need to come along and do these other things. And that is a very, very hard conversation to have. And I would say, frankly, in my experience, and I'm sure Derek has some thoughts here, but if you try to insert yourself that way and saying, we know what's best for you, again, that's kind of the AV model, right? You're probably not going to win in telehealth, and you're probably going to be pushed out. What you have to do is you have to understand what each of those two pillars of the transactional relationship need. You have to understand what the clinicians need, and you have to understand what the patient needs. There was a really interesting survey that was just completed by the awkwardly named COVID-19 Health Coalition that obviously this was in July to August of last summer, obviously in response to COVID. And it was specifically about telehealth and the rapid adoption and how that was impacting services. The number one issue, that everyone talked about, regardless of location, regardless of discipline, was access to technology capability. And some of that was, maybe a rural area that just didn't literally have technology upon which to build. But a lot of it, going back to your thing about your dad, was how do we, the clinicians, provide services to an often older population, an often technically illiterate population, while maintaining a standard of care that actually does anything for the patient and the clinician. At some point, there is a level below which you just can't go and still provide valuable, video capabilities. And obviously that is going to vary depending on what you're doing. If you are, let's say, going to a dermatologist, there's a certain, level of resolution and color and lighting that someone's going to have to be able to have at their local site, which is, of course, usually a dinner table or something like that, in order for that to work. Whereas if you're talking about mental health, that's a conversation. That maybe you don't need to have quite as expansive a customer side or device side capability. But Derek, I know that you and I have talked about this in several ways, and I was wondering if you had any sort of follow-up thoughts on that sort of clinician-patient relationship and how people can start to get into it.
Sure. Yeah, I think the name of the game now is workflow. You can't make this a technology discussion when you're dealing with sort of groups that aren't very technology inclined to begin with, while you're trying to replicate what is a very natural, hands-on, interactive experience. So we have a lot of challenges associated with that from both an operational perspective and a technical perspective to make sure that we are as closely aligning that software experience for both the patient and the provider in such a way that it's easy, it's simple. It's something that requires minimal steps. We can have that conversation. We've, in fact, maybe taken steps to prep the patient and the provider so they understand how to make that experience optimal. Go to your Wi-Fi, your best Wi-Fi source. Make sure you've got 4 bars of LTE. Upgrade your software. These are things that have become table stakes to sort of navigate this interesting time in which we see technology very rapidly stepping into these care scenarios. I think the stats are telling us that they're predicting minimally 20% of all healthcare encounters moving forward in the aggregate to move over to a virtual model. And I think that's extremely conservative. I think there's tremendous opportunity here. But the key to making that successful is getting that technology to really fall into the background behind the scenes and making sure that people don't even think about it.
Well, Joel, that is the magic bullet, right? Is getting the technology to fall into the background. How do we accomplish that, Joel? That's the you've had a number of experiences, within and out of government and healthcare and education for the last 20 years. How do we do that, or can we in AV?
So going back to that survey, I think was very illustrative. What emerged, and again, this was across all providers, all disciplines. What emerged was a picture of the preference for at least from the clinician side, from the provider side, was to have sort of a formal telehealth platform. What they want to have is a single interface where they have access to EHR, electronic health records, where they can call up at a moment's notice. The last 5 or 6 discussions they've had with this patient, they've got the patient's vital signs, if that is something that is available through that kind of mechanism. And they are not coming in and going back out and coming in and going back out. There's basically, they just live on this platform all day long, and they cycle through their patients. They have meetings with their colleagues. They record whatever data they need to. They make diagnosis. Maybe even they can have a prescription or something like that that is automated out of this type of platform. That's the main space where they want to be. But there is also what we in the IT world call the layer 8 problem. Problem exists between keyboard and chair. You have to have the ability to provide some minimal level of service. So there's always a fallback. And what emerged is that is usually, to your point from your story earlier, that is usually something like FaceTime. That is usually a consumer level video product that, doesn't have the power, doesn't have maybe the security or control that an enterprise class product does. It does at least work. So what you're seeing is, and that's the implication is that that's mostly organic, that service providers are doing everything they can to provide service. That's what they want to do, of course, is take care of their patients. And while they want this platform as primary interface, everyone knows how to use an iPad. Everyone knows how to, put an app, for the most part, put an app on a phone. So they have these kind of fallback consumer level positions. I would say that for an integrator, you're never going to get beyond that consumer level capability in terms of a fallback position, because everyone trusts it. This is kind of a slightly different version of the old Best Buy argument in AV, right? Which is, okay, yeah, you're selling me a $10,000 monitor, but I can go get one for $500 from Best Buy. Why do I care, right? So, so as long as that continues to exist, and I think particularly with things like Signal, which is an end-to-end encryption video app now doing multicast or multi-point, I think that will only continue to grow, that capability. Where the flip side of that is, if a doctor tells a patient, hey, here's a link, go to it on a browser, which is far and away the preferred model for pretty much everybody, the patient isn't going to say, well, okay, I might because that's me, but most people are not going to say, oh, I can't do that because it's not secure enough, or, oh, you know what, I've got an account on a different healthcare provider's platform. You just trust your doctor. You're just going to do what your doctor tells you to do 9 times out of 10, 99 times out of 100. So that, I think, is where integrators need to start looking, is are participating in, or possibly, as Kaiser Permanente did, building or supporting the building of a platform around a set of products, so that whether you are the video part of that, whether you are the device part of that, whether you are integrating, for example, medical devices into something like that. I know there's some really interesting things going on with operating rooms and training centers for example, nurses in rural areas, where that, of course, is a traditional AV baseline that is being pumped up into a telehealth type of infrastructure. As long as you understand, to Derek's point, as long as you understand that workflow concept, that you, the integrator, are not the be all and end all. You are participating in a much larger exchange of information, then I think you're going to start being successful, because you need to be able to have that conversation with the providers, because it's really the providers who are going to dictate the technology. If I go to, I don't know, a cardiac surgeon and say, well, I'm on FaceTime or I'm on this other platform. Cardiac surgeon is going to say, okay, that's great. I don't care, because I work for an organization that has 10,000, 100,000 users, and we use this. And that's where all of your information is. I'm not going to build something just because you don't like it. So if you want to talk to me, this is what you are going to use. So the providers have almost all of the power in that exchange to dictate. So if you want to, if you are a small, medium, or large integration business and you want to start to look at this model, play to what you know. Obviously start with, that the physical layer, but recognize that the physical layer is the edge. It is just a way of getting into the workflow. It's just a way of getting into the applications. Tim, you and I have had this conversation many times, but I will say it again. To me, everything is an application.
Yeah.
Even things like microphones fundamentally are applications, because they have a purpose, they deliver a product. And it's really just about how we take that information and process it and distribute it. And so it's going to be, if you don't have that mindset right now in our industry, you're probably not going to be doing very well, certainly in telehealth, but I'm going to suggest in the wider industry as well. Yeah. So very long answer to your question.
No, it's fine. Derek, I want to bring you in on this from the software side. Is looking at, what integrators are able to kind of change their mindset a bit, and when they're talking with their clients and trying to get out of them what it is that they need. And that workflow, go back to that you were talking about for a second, is, trying to understand what it is that they're looking to accomplish and then delivering that, right? So from a kind of a full stack standpoint, how do we get, our listeners and dealers and your clients to, dig in and discover what it is that they're specifically now the healthcare clients need, and how do they deliver that? And then the second part of that question is how do they communicate what others are doing if they're just now starting down this path?
Sure. So I think it really has to start with, again, what problem an organization is trying to solve. You may have emergency department utilization issues. You may have access issues. You may have long waiting lines for certain clinics, and you're struggling to see, where I can route that traffic. And it's interesting because video becomes a mechanism by which you can do a very rapid sort of analysis and triage for what the patient actually needs. And so that's where I think we're seeing some of the efficacy in terms of how flexible this platform can be for healthcare. But from an organizational perspective, you need to understand the outcomes that they're driving to, right? Video effectively becomes table stakes, but what are the touch points within that health system that maybe are overutilizing video in an inappropriate fashion, maybe impacting patient satisfaction scores? Maybe they're underutilizing it, and they can actually add more efficiency into their existing clinical staff without having to go contract out and make large investments in full-time employees. So there's a lot of different ways that you can kind of, attack that problem. I think from my perspective, when you're looking at technology and we're talking about just tools, you want to keep that flexibility in place. So an organization may have made a tremendous investment in a Cisco or a Zoom. That's all well and good. But now let's talk about, the care that you're trying to deliver, beyond video. What are the gaps? What foundational components do you want to add in? As we watch this industry evolve to again, following Jill's point, do you want to do real-time diagnostics? Do you want to bring in additional telemetry type of data points, that will assist and improve the level of care that you can deliver? Maybe I want to look at endpoints that I can deploy into the patient homes, for follow-up and post-acute settings. That's a big transition to make. And I think, from a platform perspective and from an application perspective, you need to keep all of those facets in mind as you try to navigate those waters.
All right, very good. As we wrap up here, I mentioned some of the legal challenges, and I'll pick on New York for a second because this is the story that I was told and read in a couple of different places, and that is New York State and New York City specifically has long resisted telehealth. In my understanding, is for litigation purposes and malpractice purposes. Well, when the COVID lockdowns began, the medical community was left with one of two choices: either don't service your client, your patients, or get on board with telehealth. And Joel or Derek, either one. How do we help not just New York? Again, I don't mean to pick on them, but that is the story I read. But other organizations who are looking at telehealth and might be a little skittish, again, because of malpractice, because of lawsuits, or because of other reasons. Either it's a cost prohibitive, they think, or it's technology prohibitive, or they don't think that their clientele is necessarily going to jump on board. What advice would you give to dealers, talking with their clients, or specifically to the medical community to get on board with this?
So I would say that this is a learning experience, and you just have to kind of dip your toe in the water and really start small. When you look at certain types of interactions, you may not want to jump into wound care. You may not want to jump into something a little more advanced. You may want to start with your behavioral health, where again, it's just a conversation. It's a natural extension. And then, gradually see how your patients are reacting, take careful measurements along the way, and understand, is this improving the lives of my clinicians and my patients? Are they overwhelmed? That incremental approach is, I think, how any organization is going to have to adopt telehealth, because this is relatively new. It's hard. The last mile is hard. Operational support is hard. So there's so many things to work out along the way. If you just go all in, you're setting yourself up for some failure.
I think too, one of the, and first of all, I will absolutely second what Derek's saying, especially about behavioral health. One of the really interesting things about that COVID-19 survey was something like non-behavioral disciplines, only about 10% of them had been doing telehealth before COVID hit. Yeah. With behavioral, it was actually closer to almost 25%. It was between 20 and 25. So that trend had already started. And to Derek's point, that's, again, that is conversational. There's that is an easy realm to start to break into. I think too, ultimately a lot of this just comes down to understanding the customer and understanding how to make a sale. There's this probably the biggest thing that you have to be concerned about in telehealth from that perspective is reimbursement. This is a Byzantine world to those of us, and I raise my hand here, myself very much included, who do not work in the insurance industry or things like that, or aren't Medicare providers, for example. But for the very, very large majority of us, these are services that are essentially paid for by someone else according to what's called a fee schedule. And that was also one of the really big concerns that we saw coming out of that survey was fee coverage, reimbursement, whether it wasn't enough or didn't exist at all, from whether it was health insurance, whether it was Medicare, whether it was government, state, local, whatever. But the flip side of that is, and this you're seeing more anecdotally from conversations, if you're talking about behavioral health or even primary care, whereas before they might do, let's say for sake of argument, 2 interviews in an hour or sessions in an hour, especially for things like primary care, pediatrics, geriatrics, things that tend to go fairly quickly and are relatively routine. You're seeing that number get up to 6, 7, even 8 sessions per hour.
Good night.
So now, obviously, different clinicians have different approaches, and we would never advocate, compromising care quality in any way. But if you think about it, when you go to the doctor, traditionally, you sit in a waiting room, someone takes your vitals, you sit in a room, per 5-10 minutes, and you only ever actually communicate with your physician for maybe 5 to 10 minutes.
Yeah.
Everything else is based on, writing everything down and getting everything organized and things like that. But that also means that the physician can only ever charge for you, because you only had one session. Whereas if they're able to have 5-6 sessions per hour, all of a sudden their volume is skyrocketing, and we are seeing that. Our biggest customer, Pexip's biggest customer, is the VA, which is currently doing, I believe it's something like 150,000 sessions per week.
Good.
And obviously that's because of COVID, and the world will reestablish a new baseline. But to Derek's point, it is not going to be the old one. People like this. They like being able to, just register with a Doxy or an American Well or Epic or something like that, and just be able to have their session and, not have to drive anywhere, and, get a prescription that gets mailed directly to their house. So will things reestablish at kind of a lower level than they are now? Probably, because you still want to be able to. There are certain things that you have to go to a clinic for, but we are definitely entering a new phase of clinical care in this country and worldwide. So being able to participate in that conversation, I think, is going to be really important.
Absolutely. All right, that'll be a good place to stop it. Thank you both so much. Mr. Joel Billheimer from Pexip. Good to see you as always, sir.
Thanks for being here, sir.
How do people get a hold of you or Pexip?
I am at firstname.lastname at pexip.com, and I do have a LinkedIn account. Still no Twitter, though. Sorry.
Or Facebook, or LinkedIn, or Friendster, or MySpace, or anything else. Derek, thank you so much, sir. Nice to see you. Nice to meet you. How do people get a hold of you?
Same, firstname.lastname at pexip.com or LinkedIn.
All right, very good. My name is Tim Albright. For us, for AVNation, go by our website, avnation.tv. That's avnation.tv. You'll find programs like this and a host of others, including our 2 weekly programs. One looks at the residential side of the AV industry. The other looks at the commercial side. The residential side is called Resi Week, crazy enough. And the other one is called AV Week. So check all that out and more at avnation.tv. That's avnation.tv.